Okay. Good afternoon, everyone. We're on our final session today, and thank you all for listening, and it's been a great day, and I hope this will be a great session too. I think it will be. So our closing session today is around before I start, I have to thank the sponsors. Now, I always forget that. So I really want to thank our sponsor, which is GMHBA. And I also want to remind everyone that this clinical pathway is connected with the Youth Mental Health Pathway on Health Pathway, which has got so many great resources there. So remember that. So our closing session today is a panel discussion on youth mental health, connecting the dots. We have a really great, excellent panel of different health professionals with all different expertise and knowledge to share with us. And we will have an opportunity to ask some questions at the end. So we will make sure we have time for that. So just to introduce this session, I think we've heard over and over around COVID has brought us a lot of challenges around mental health, and particularly around young people and access to services. I think we all know there are huge gaps for all mental health, and particularly for young people. And as health practitioners, we're all sort of navigating this, and it is difficult. We really don't want this session to be about the gaps, because we know they're there, and we can't actually do much about that in this session. So we really wanted to concentrate in this session around what can we do with what we have. And this group really have a great knowledge of what's out there. So we're really hoping that we can sort of give you some extra tools that you might be able to use. So we're going to start the panel with just everyone introducing themselves. So we will start with Dr. Sue Barker, who's a GP at Headspace. I'll just put it over to you, Sue, to introduce yourself, please.
Yeah, hi everyone. I'm Sue Barker, so I'm a GP at Headspace, and I also work 1 day a week at Newcombe Secondary College as part of the Docs in Schools team there.
Thank you, Sue. Secondly, Dr. Bianca Forrester, a GP specialising in adolescent health.
Hi everyone, Bianca Forrester is my name. I'm a GP also working in the Doctors in Secondary Schools program at North Geelong Secondary, and I play a role as an academic for the University of Melbourne Department of General Practice. I did a few years ago a grad dip in adolescent health at the Uni of Melbourne, and for the University of Melbourne I'm now the Clinical Training Program Manager for the statewide Docs in Secondary Schools program. Thanks.
Thanks, Bianca. Sean Duffy, who's the Ballarat Community Health CEO. Sean.
Good afternoon. Yeah, Sean Duffy here from Ballarat. I'm the CEO of Ballarat Community Health. We're sort of an integrated community health service that runs a range of mental health and drug and alcohol primary care services around the Central Highlands area of Ballarat. Good to be here.
Thanks, Sean. Sian Pritchard, who's a nurse practitioner, and she specialises in mental health and addiction and young people, and she also works in schools.
Hi everyone, yes, I am a nurse practitioner in private practice in Geelong. I also go out to schools and do clinics. Been nursing now 37 years, and for the first 18 of those I was an emergency nurse. And I became interested in how young people accessed healthcare in the community, having seen lots of young people come through the emergency department intoxicated or in psychological distress. So that's, I guess, what pulled me out into working in secondary schools initially, and then I worked for the Jigsaw Youth Mental Health team for many years, and then moved into private practice 6 years ago. And I'd like to think that I help people navigate some of the systems that can be quite tricky for them in the community. Thank you.
And finally, Dr. Bo Egan, who is a youth psychiatrist.
Afternoon, everybody. My name is Dr. Bo Egan. I'm a psychiatrist, youth psychiatrist working in Geelong, Barwon Health, predominantly working with the Jigsaw Community Mental Health team there.
Thank you, Bo. So I'd now like to just open up a case that was one that I brought up a few issues. So our case is Carly, and she's a 13-year-old girl, and she's been brought into her GP by her mum, who's really worried about her. Mum's worried because she's noticed Carly's been quite withdrawn and she seems really sad. And she's also noted that her eating is quite disordered. She's not eating breakfast, she's not eating her lunch at school, but she's actually eating a lot of sweets and chocolates in her bedroom, finding the wrappers in there. And she's also noticed some cuts on her forearms that she thinks may be self-inflicted. There's a bit of a background there. Late in her primary school years, she has been diagnosed with a mild learning difficulty in Year 8 with dyslexia. She was really challenged during homeschooling during the COVID time, and her mum felt that the school really didn't support Carly's learning during that time. Carly admits herself having poor self-image, and freely admits that she doesn't feel very good about herself. She also has quite heavy periods, and has missed school on the first day of her period due to pain, and they're very heavy, and her mood is even worse pre-period. Her parents are separated. They actually had quite a difficult separation 3 years ago, and they don't get on very well. But Carly does spend time at both parents. She's the youngest of 3 siblings. Her BMI is normal at 24. Her hemoglobin is normal. Her ferritin's a little bit low, 17. She did see a psychologist for a little bit, but was online, and she really found that difficult, and she really didn't gel with this psychologist. So Mum's bringing her in, for us to have another look at her, but perhaps to link with another psychologist. So what I'd like to do is just put it to all of our group just to give us a little bit of their perspective on this case, where there's actually a lot going on. And as a GP, sometimes you feel quite overwhelmed where to go here. So I'd like to ask Sue first, if you could talk a little bit about this.
Yeah, thanks, Anne. So there is a lot going on, but hey, this is not uncommon, and especially post or during COVID. So the GPs I think they've got a really important role, not just in holding if the young person is referred, but also ongoing, because this young person needs a GP into her teens. So for that reason, you really need a really good understanding of what's going on for this young person. So I know, Anne, there's a lot of history there that you've just told us, but I'd be going back and doing a really enhanced assessment. And in particular for this young person, I'd be looking at the risks. We've just listened to Louise Stone talking about adverse childhood experiences. So looking at the risks, at the strengths, at the supports that she has, and all the time having in mind that the supports that she doesn't currently have. And I think we need more information also about her mental health systems and the history and the acuity of all of those things. So you would certainly be needing to do a safety assessment for this young person, but also the history of the eating disorder. Is it actually a diagnosable eating disorder? And if eating disorders, a colleague has said an eating disorder exists to tolerate the intolerable. So you need to know what's going on for this young person. And I'd be focusing, a lot on her strengths. So for the second thing would be for a 13-year-old who's got mental health symptoms, you need to involve the family. And I feel quite strongly about this, that we know that young people with cushioning do better with their mental health overall. But in particular with eating disorder symptoms, it's family-based therapy is the only evidence-based treatment. So you really need to, for this young girl, go out of your way to include the family, I think, and support the family as well. So I'd be getting consent to communicate with the school. And I think that Bianca will speak more about this and fill in the gaps that I don't talk about. But with the school, I think, is this a diagnosed learning difficulty? Because if she's had an educational support, that will come with strengths and weaknesses, and and recommendations. And so is the school following up on the recommendations? Have they communicated this? Year 8 is absolute classic time for young people who have got mild learning difficulties to begin to disengage from school, because overload, everything becomes more intense. And young people with insight just see that gap between themselves and their peers. So it's absolute classic time. This girl, I would think, it could well be at risk of disengaging from school. So what hooks are there at school to keep this person engaged, and what supports, which Bianca will talk about, I think, are available to her. So communicating with the school is so important. And then in an ongoing way, I mean, this has been mentioned in the previous talks, GPs have got the skills. And so depending on her capacity and depending on what's the most pressing thing for her right now, I'd be getting my skill set of, cognitive behavioural therapy / brief interventions, and seeing what can I do in the following sessions to help this young person. Is her sleep terrible at the moment? Can we do a session on sleep? Is she getting really irritable all the time, which is really common? Can we do some psychoeducation around that? Does she need help with emotional regulation? So I think it's great to have a folder. You've got 6 sessions that you can go ahead with. We've already got the skills. It's just having them there, good to go. I mentioned earlier about supporting the family. So there are family supports there. I don't want it to be Geelong-centric, but there are, it may be that apart from resources that are available online for families, there's also, we've got in Geelong, and I'm sorry, it's Geelong thinks that's what I know, but there's Drummond Street, Bethany, BCYF Youth and Family Services, as well as various groups that are available at Headspace now. So, yeah.
Thank you, Sue. That's such a great start to break this down. So thank you. Bianca, can I put it to you? What can you add to this?
Yeah, so I guess at kind of face value, this young person's representing saying they didn't gel with the therapist. And I think on the one hand, as GPs, we sometimes think, oh, no, we've tried a line of management and now it's kind of like we're having to rethink it. But I think sometimes you've got to think about, well, what is the opportunity here? And because we do try to break things down into chunks, I think sometimes we're at risk of maybe developing that mental health care plan, a little bit quickly. And I do agree that really was so, to really understand and deepen our formulation and assessment, this is an opportunity to do that. So this next appointment I see is that, okay, well, let's now deepen our formulation. Let's think about those predisposing factors, precipitating factors, perpetuating factors, and protective factors. And, as Sue describes those, they're the risks and the strengths. And, we can kind of have this time to come back at this kid and say, okay, this is a kid who's 13. She's going to be a COVID 7. So these COVID 7s are going to face a lot of challenges. They had a bumpy transition year. For any kid with any type of neurodevelopmental disorder or speech and language issue, that year 7 transition was always going to be hard. It was always going to be a bit anxiety provoking. And we've put the added, we haven't, but the added challenge of COVID's probably made that extra hard. So you always do see, year 7 transition is a typical time and where I guess the stresses and pressures are there for these kids who may have learning issues. And then, as Sue says, by the time they get to year 8, that's often when the cracks kind of start to show. But these kids had those extra stresses and pressures, the COVID lockdowns, the fact that learning was potentially even more hard. So while all young people face challenges, those who have social disadvantage or learning issues will be disproportionately disadvantaged. So we've got to think the stresses and pressures when it comes to learning are going to be high for this kid. Add in there the fact that her parents have split up, and I'm not sure when that sits contextually, but there's an extra complexity now to her life. Is she working across 2 different households? Is she working across 2 different households during the pandemic? And how are her parents? There's going to be a lot of stress in their life. So how are they going, and how's their mental? So again, bringing it back, as Sue describes, to that family dynamic and that family unit, and trying to kind of see this kid in context. So, we talk about the 4 worlds of the adolescents, and I think we know about heads, but I think about the 4 worlds of the adolescent: the family, peer, school, and community world. When it comes to, feelings of anxiety, which we basically see as a subtext, she's got maladaptive coping, right? She's self-harming and disordered eating. So she's feeling stress, and she's doing the maladaptive coping in response to stress. So what are the stresses? What are the pressures for this kid? And on the one hand, while providing CBT is building her skill, how can we actually decrease challenge? So how can we help this kid in the face of these pressures and stresses decrease the challenges she faces? Can we slow everything down for her a little bit this year in year 8? A lot of kids are now stressed at this point because they're back to somewhat normal. Those who are finding it hard to catch up are feeling disproportionately stressed. So how can we slow it down for her a little bit and match her kind of challenge with her capabilities? As Sue says, look, there's stuff that's offered in the schools. If she's at a government school, there's been extra investment in catching up and extra tutors. Is she actually accessing any of these supports that are available? As Sue says, if there's been a diagnosis, there'll be a learning plan in place. Let's hear if that's been felt by this family. And the way you can review that is you can ask you can get in touch with the teacher. All schools have a structure, so the teacher will be able to elevate to, say, a year level coordinator who might make a referral out to student wellbeing, and together they can create something called a student wellbeing meeting or an SRG meeting where they catch up about the young person's kind of behaviour, academic performance and well-being, and they can implement a plan. So this is kind of one of those opportunities where those elements of school get together with the parent and perhaps the young person to try to kind of create some plan. I think that there's those kind of opportunities within the school to try to look at taking away the pressures and stresses within that school context. But then thinking about, well, what about the family, and how do we, provide her with the a less stressful environment? How are things tracking with that move between households? Are the parents getting their mental health care needs met? So I guess while we've sent the young person for counselling, because the young person's facing issues, is that coupled with the parents getting their mental health needs met so that there's a less stressful environment for the whole family? I'm going to pass it over because I'm probably out of time, and I think we're going to have another chance at this, and to kind of get down into some of those other issues. But I think oh yeah, sorry. Do you want me to
your
move on
mic?
now?
No. I was going to say I've just got a message that your microphone needs to be turned up a little bit. Just a
Okay.
technical thing. No, but that's really great. So I think
Thanks.
I wanted to ask you. I like that the 4 things for
4 worlds of the adolescents.
So that was
we think
family,
about
peer, school, and what was the other?
community.
Community
World. So I think
Community.
that, while we do our heads assessment, this is just another way that I like to think, is you think about those worlds that a young person inhabits: the self, the peers, the school, the family, the school, and their broader community. And you seek out, when you're talking about anxiety, you seek out the stresses and pressures that exist in each of those worlds for them. And you're thinking about ultimately building their skill to cope with those stresses and pressures, but also looking about whether we can actually decrease the challenge for that young person, particularly at times when they are in crisis. Because let's face it, if she's going to try to do something like CBT, again, quick note on that, if she's got a speech and language issue, is a language-based therapy going to be a little bit challenging for her, or does she perhaps need a little bit of extra scaffolding there? But someone else might cover that. But, thinking about, well, we can build up her skills, but actually maybe sometimes it can all be a bit too much, can't it? And that sense of overwhelm, I think we see happening when we have kids who are self-harming, is that they're just overwhelmed. So how do we, just decrease that challenge level a little and just slow everything down for them a bit?
Yeah, I like that. Do you look at this decreasing the stress and increasing their skill level, and
That's right.
work
And
on
I've
either?
talked to them about that. Yeah, trying to get that optimum balance right, you know.
Yep. Thank you, Bianca. That's a great way to look at this case. We're going to take over to Sean now, who might have a different way to look at this case.
Not so much. I agree with
Sean, I'm going to interrupt you. Your sound's not quite right. So I don't know.
Is that any better?
Not really. You haven't got any microphone or anything you can use? No, we might. No, we'll have a go. We'll just have a go. If it's too hard to hear, we might have to move on. We'll see how you go.
Is that any better? No.
No.
Apologies. I hope, I don't know if you can hear me now.
That actually is a bit better. Maybe even a little bit further away from your microphone might help.
Yeah, okay. Please let me know via the chat if you can't hear me. I think the points have been well made by Sue and Bianca. I would say one of the things that I've certainly found over a long time working with young people is don't rush the process of getting to where you want to be. And I would imagine that Cully's going to be quite ambivalent and quite concerned about what are the next steps and even her capacity to be able to understand it. So it's trying to manage this anxiety between the family wanting a quick resolution right now versus maintaining a connection and rapport with Carly over a period of time. And it might depend in terms of the region, what supports you've got available. And in some instances, the GP or practice nurses or local area mental health might be all that exists. And we know that psychologists are not readily available. And so I would say that what's most critical in this instance is certainly that notion of considering what I call the social health framework, which certainly Bianca touched on, but making sure that over time that Carly doesn't disconnect. So rather than immediately starting CBT or certainly starting on some basic solution-focused work seems like a logical way forward, but hoping that Carly will connect with turning up to appointments on a regular basis. It might mean that the family require a little bit of intervention before Carly does. Understanding that there are some obvious things in terms of risk assessment that needs to be considered in the initial phases. So my points are that I think Sue and Bianca covered it quite well in terms of the considerations, but in terms of the process, I'd strongly encourage that it's a slow process because Carly's going to require a number of years, one would think, in terms of tailored intervention.
So I think I was going to ask Sian. Can you speak?
Yes, hi. Just great points made by everybody so far. I suppose my role as a nurse practitioner is different to the GP's role, and I guess I see myself as being able to support GPs in that we have the benefit of being able to spend longer in the room with young people. GPs are often, even if it is their specialty area of practice, they can be really time poor, so that can be helpful. Sean, you mentioned practice nurses. I think practice nurses could have a much bigger role in this space. I think we underutilise the wonderful strengths that practice nurses have got in engaging with people and engaging in their ongoing healthcare. There's a couple of things specifically around this young person. I guess I would get her to do things like, maybe chart her menstrual cycle against her mood. There's some great apps young people can, put in if they're feeling angry or happy through the month to get a bit of an idea if there's a hormonal component here. I think talking to parents is really important, particularly around this sort of eating stuff that's going on, and encouraging the parents to normalize eating and have family meals together. What else was I thinking of? I guess trying to inquire about what hobbies she might have. Last year was so tough, wasn't it, on young people, not being able to do their, normal everyday things. And just checking in, on those friendships, and if she's been able to get back to doing any hobbies, any physical activity. We know that, young people who are engaged in physical activity and eating well, much more likely to have good mental health as well as physical health. So I think that's probably about the only things I was thinking adding in. There is a really good online program called the BRAVE program. Now, that is based on CBT. But it's cleverly done because it's an animation, sort of cartoon, very pictorial, engaging for young people, and that's certainly something that young person could do on their own, or with their parents, or or with, if they had a therapist or a nurse to work through it with them, they could do the sessions together, so that if there are any difficulties understanding anything, then that could be teased out a little bit more at the time. That's it from me.
So the BRAVE program, we might see if we will send a link to everyone about that one, because it might be a good one that we could use, recommend. Dr. Bow, could I put it over to you?
Great. It's always hard being the last speaker. I'll probably just end up summarizing a lot of what everybody has said, but also expanding onto that. So look, I think to help us figure out if her mood is related to her menstrual cycle, as Sian mentioned, getting her to just do a mood diary for at least 2 cycles, where she just tracks her mood, any behavioral changes and physical symptoms as well related to that. We also know that, research in diet and adolescent and low socioeconomic communities, there's a correlation between diet and low mood and depression. So optimizing her diet is important. We know that the Mediterranean diet has been helpful in reducing mood, or improving mood, and reducing depression. Increasing fruit, vegetables, legumes, seeds and grains is important. Also, foods rich in omega-3, polyunsaturated fatty acids, it's also really important. And in particular with Carly, reducing processed foods, fast foods, and sweets as well. Sleep, somebody mentioned sleep. Very, very important, as we know that optimal sleep actually reduces the inflammatory mediators related to low mood as well. So promoting and educating her sleep hygiene is going to be important. Exercise as well is going to be important, but also being mindful that this is a young person that may have body images. And again, just assessing how much she's exercising is important, but finding that balance, I think, is important. Psychotherapy, everybody has mentioned it, so CBT, but also I think Bianca made a really good point in terms of what her capacity is and what her cognitive capacity. So we may just focus on more behavioral therapy, such as, relaxation, breathing techniques. Mindfulness is really important. I think Louise mentioned in her prior speech, talk in terms of Smiling Mind app. That's always a winner for everybody and really helpful. Sian as well mentioned before, building that therapeutic relationship. That's really going to be the key. Taking your time and building that relationship with her. That strength-based approach as well in terms of building her resilience is going to be key and important, and that's going to be more that longer-term work that you guys do. So when we look at pharmacological options, we know that if, we suspect that there may be some premenstrual syndrome or possibly PMDD, so premenstrual dysphoric disorder, which, somebody will have more significant impairment or function in terms of work, or, well, for her, it'll be school or relationships. Vitamin B6 has been found to be helpful. Doses between 50 to 100 milligrams have been proven to be efficient. Don't go over 100 milligrams, as that can be related to peripheral neuropathy as well. There's limited evidence, actually, in terms of primrose oil and St. John of Wort for PMS and PMDD. Then we can also consider oral contraceptive pills, so Yasmin. So those oral contraceptive pills that have drospirenone are actually been proven to be great in PMS and PMDD. And also the oral contraceptive pill Zoli, also really helpful. Ensuring that they take it continuously and limit the sugar pills as well. I wouldn't particularly consider it for Carly, but for maybe some of your older patients, or if you feel like you've tried other options as well. So low dose SSRIs may be an option, where you either prescribe it low dose throughout, without, just throughout each day, or during the luteal phase only, or you could potentially do low dose SSRI with higher dose during that luteal phase as well. I think everybody has also mentioned the importance of involving family. That's really going to be key throughout when we're considering the potential, disordered eating patterns. It's important to obviously monitor her weight, check her vitals, monitor ECG and electrolytes, especially if, there's purging behavior or use of diuretics or laxatives as well. That's going to be important. Assessing her severity using the EDEQ, and checking her eligibility as well for the eating disorder plan. And there's actually really great resources with the Butterfly organization, and they provide support for professionals and individuals and family as well. So that's worth considering. And that's it from me.
A lot of information in there, Bo, actually. You've given us so much to, it's a grading of, you wouldn't necessarily do all those things all at once, but they're good to have in the background. I am going to ask you, EDEQ, is that the eating disorder? What does that stand for?
Oh, goodness. Yeah, it's the eating disorder questionnaire. I think that's part
okay.
of. Yeah.
Okay. Yeah. It's a questionnaire. Yeah.
Yeah.
Okay.
Cool. Yeah.
Sorry. I should probably know, but I just didn't. Okay. So I am just going to push you a little bit in terms of one of the questions I have just at this point is we've all discussed about involving the family. What tips have you got about doing that, Sue? I'll start with you.
So I think, did this girl come along with her family?
So she's come in with her mum.
Yeah.
Dad's actually a little bit disengaged from her, might be part of the issue. But so she's got two older siblings. Mum's very worried, mum's very connected to her, but Dad's a little bit on his own little tangent here. So any tips around how we involve the family? And she spends a week with Mum and a week with Dad.
So you probably the first appointment is going to be with Carly herself, but I would be saying up front, it's going to be good here to have. It's great that Mum's brought you into this appointment. It'd be great if we could keep her in the loop. And I actually usually say that because we know that young people that are struggling with their mental health do better when, they have a nearest and dearest involved with their care. So, and then if they're reluctant, I will offer can I help you with that? So maybe we can book a session next week and you can get Mum to begin with to come in with you and we can talk about what's going on for you together. And so that in that way you're you're helping the communication and breaking the ice, I guess. And I would also be linking or suggesting some resources for Mum. So particularly for this young person, I mean, if she's got eating disorder symptoms, so there's a really great resource on it, just on the Headspace Nationals, Understanding Eating Disorders for Family and Friends, I think it's called. So, and there's a similar one for anxiety. There's a similar one for other things. So just starting with that really basic stuff. I think if you've done that thorough heads, you're going to know just how much difficulty there is with the relationships in this family. And so I think you'd be making a call, just how much support does the family need? Am I actually looking at getting some one-on-one family support? Is that what's needed at this stage, or is it just that they need this gentle introduction? And I think it's important to keep parents informed. Like, you're not going to have these sessions with mum or dad every time, but I do think at 13 it's important that they feel like they are being kept in the loop.
So, Bianca, we've got 5 minutes, guys, so we'll probably have to be, just fairly brief about how you would involve the family.
Okay, so look, with a 13-year-old, mum's brought the young person in. I like to just say, we'll bring mum back in again. I think really when you're exploring with that young person, what 13-year-olds tend to say is that they mum. It's like they know that they've got lots of worries and their feelings are too big for their own body, if you like, and they know that mum's really stressed and they don't want to worry mum. So you've got to overcome that myth, I think, and just really let young people know that that is the most important thing to all parents and that they will want to be involved. I think going back to the kind of what can she potentially do with CBT, and as we were describing, maybe some just behavioural tracking, I think you can kind of get parents in to understand what are the basics we mean about behavioural tracking. And I think a quick one is ABC, antecedent behaviour consequence. So, when did you allow self-harm? What was happening just before that? So you're thinking about, what's the trigger? Then what's the behaviour? And how did you feel a bit later? So with self-harm or with any kind of maladaptive coping, the way you can tell it's maladaptive is that there's usually a sting in the tail. So they'll say, well, I felt shamed, I felt guilty, or I worried I would hurt mum. Okay, all right. So then when we're going to change it, let's go back to the beginning and think about, well, what could you do differently next time? So you get them to try and do some of that. And I think you've got to help mum and dad tune into kind of that this is a strategy we'll use and that they're going to be supporting her in using those strategies. Because often the parents just get really frightened by those behaviours, but they find it really hard to tune into the emotion behind the behaviour. So I think you're really trying to help the young person. And the young people also want parents to understand the self-harm, so that might be something that she says is she wants mum and dad, they don't really understand the self-harm, and you can say, well, I can help mum and dad understand it and give them some structures and scaffolding around, well, how could they help the young person, implement more healthy coping strategies. So that's, I guess, a simple thing that I would do around involving parents. Is just to help bring them in behind that, implementing those strategies we're trying to use. Thanks.
Great. Yeah, I really like that. Okay, Sean, would you have any ideas about how to involve the family?
I think it's pretty much covered. I think what's really important is transparency from the start in terms of the agreed process with Carly about what you talk to mum about and what you don't, and be upfront about it. I think it's going to change throughout. So one minute Carly may want mum involved, next minute she doesn't want her involved and wants dad involved and doesn't want dad involved, and I think we've just got to be open to the fact that it'll change. But I suppose above that is some principles in terms of what's going to be disclosed and what's not going to be disclosed, and being quite open about that, so that you're really honest from the outset. What you don't want, of course, is any sign of that you're talking to mum behind Carly's back, because it's just an opportunity for Carly to disengage.
Yep, that's great points. Sian.
I might just mention, when I said about the BRAVE program earlier, there are 3 different age levels that can be done. So 2 primary school ages and high school ages. And there's actually a parent portal as well. So parents can have their own login and learn all about it. So that can be quite helpful for parents to understand, how they might be able to help. And I think even things like when we're teaching young people about relaxation or meditation, that can often be something that, a mum and a daughter or a dad and a daughter can actually do together of an evening, where they can do a 10-minute or a 15-minute relaxation session together, which, can just be a nice downtime for them to spend some time doing something that's going to be helpful as well. That was my idea.
It's like a great idea. Yeah. That's both modeling that this is good for everybody. This is not just for you. We all need to take this time to relax. Bo, have you got any other ideas about how to engage the family?
So pretty much, again, what Sian said, I think about being transparent is really important. I typically also just mention, again, look, I will involve mom, getting input from mom so that I can have a better picture and have that richer formulation that Bianca mentioned before. And I'll just let Carly know that from the get-go. I also, from the beginning, like to let everybody know that everything is typically kept confidential. Obviously, some information may be shared between health professionals such as psychologists or anybody else with their permission. But also when I am concerned about risks towards Carly, or Carly towards her siblings or anybody else, then I am mandated to, involve whoever is relevant or needed to. And I always find that really important to disclose from the get-go. And I really liked Sian's concept of involving family in that therapeutic process as well. And that also goes for modeling healthy eating as well. And hopefully that will help build that self-esteem by involving the family members, because that we know will build, a stronger attachment to those caregivers as well. So, yeah.
And maybe cooking meals together. Just those simple things, yeah. So thank you, everyone. I'm going to. We've got time for some questions now, so I'll read them out, and if someone thinks they can answer it, maybe just put their hand up. I think that might be the easiest way to manage that. So Roderick Taylor asks, one of the most confusing things is the way each resource changes its parameters: age group seen, income bracket seen, suicide risk seen, Headspace, Jigsaw, primary mental health partners, Surf Coast mental health team. Can we make this simpler? So that's really about not so much gaps as just it's hard to navigate all the different services and what they do. Sue.
I can't answer it, but I can comment. I absolutely agree with you, Rod. I work in it and it's changing all the time. I can't keep up with all the requirements and the services that are available. And, even within our own service, I've only just in the last couple of weeks learned about some new groups that are available, which sound fantastic, but, I think it's important to know what's out there. You've just got to keep looking, because it's there's lots out there, but there's nowhere where you can access it easily, and it's very frustrating. I totally get it.
And I suppose Health Pathways, if that's up to date, might be good ones. Sian?
I just wanted to mention the new Head to Health, which can be really helpful for the community to navigate and also for practitioners to navigate. So that's the new sort of, I guess, primary end of triaging in the community, but that can be very helpful in navigating. It is really tricky, because when we work in the area of mental health, we're much more aware of what's available. Very difficult for GPs to keep abreast of things. But I think, Westvic PHN can do a lot to assist GPs in staying up to date and letting them know about, the different things that are available to people.
Kathy Turner, I'll go on to the next question. I think Kathy Turner, I think it would be really worth establishing how much parental separation has impacted on her. I would be trying to get the parents on side with family therapy. If her parents can present a united front and do activities with her together, that could be amazing. So, just around, that separation and her navigating that. I don't know if anyone's got any comments around how you would do that. Bianca?
One thing that I was thinking about, when you think about young people with low mood and feelings of sadness, you do just ask that question of, well, what's the loss? And I think sometimes actually just having that conversation with the young person is, what have they lost and what are they grieving? And seeing it through a depression and low mood through that processing grief lens. And I think also highlighting that story behind that feeling, if that is there, enabling mum and dad to see that, I think, again, so that they can tune into what's really happening for this young person, because she does need time. I guess that she needs some time to process it. And I think, like, Sean was saying, that may take many years, but I think letting her know that that's okay and that those feelings are really valid can just be the beginning of it, can't they?
And I think in this case, it might be hard to get mum and dad in the same room, actually, which is often what happens, unfortunately, when difficult separations.
Well, actually, sorry to jump back in again. I was just going to say, when we talked about, I think Shana was with your lot, what would you want for family-based therapy? You'd probably, because you've got separate parents and you're trying to work with parents and the young person, if we're thinking about the ideal of family-based therapy, it might be like 40, 50 sessions, which you don't get on a care plan. But I'm just thinking, because GPs, we like to open doors, right? If you did an EDEQ and she just happened to have a score of more than 3, she'd get, 40 psychology sessions on an EDEQ. You've got a whole lot more sessions up your sleeve. Now, I know we're managing the eating disorder, but if some of the, I guess, precipitating factors are the separation, suddenly you've got 40 sessions. So I don't know. Sometimes it's about working out how to open
how
doors,
to navigate this. Yeah. And if it is disordered, it's fine. Okay. 4 minutes. We just need an updated one-pager regularly, and that's really a comment around a mental health service. So that might be back to the PHN, perhaps. I don't know whose bag that goes to. Would be good if every new organisation or program informed PHN so they'd be incorporated in the referral pathway lists. There is an opportunity to define target group, scope, etc.
Can I just comment there, Anne? Yeah, sorry, I'm bursting. That's fine. So I don't know if you remember a couple of years ago, this was something that GPs expressed that they wanted, because this is not a new problem. And so they requested that we have a page of on health pathways of all the youth services and that it be regularly updated. But I was advised maybe, 4 or 5 months ago now, that page was not going to go ahead because it didn't fit with the health pathways format. So it would be fantastic if GPs, still really want this, that you could feed back to the PHN, because I think it would be really, really useful. And I agree, it's not like, sore throat, what do I do, and follow the pathway, but just have it, because people access health pathways and it's so easy to access, just having a page there with all the youth services like mental health, homelessness, drugs and alcohol. So you'd have the main headings, then with all the services, and then it's updated, let's say, every 6 months. I actually think that would be great.
Yeah, I agree. Sean?
You could talk about this for days, and it's something that I do every day at work. I think one of the things I think we should put to the PHN is, within the next 6 to 12 months, we're going to see significant changes in terms of the rollout of the Royal Commission in Mental Health. And what we're going to see is new services come on board, which has the risk of complicating the problem we're talking about. So I would say that we put it down as a piece of work that must be done in the context of the rollouts. My final point, just back to Carly, is what we did a lot of times with young people is get them to, rather than speak, but draw, and actually the circles of the people that are the most closest to them. And I've found that over my years as a clinician, and certainly it's quite enlightening as to who are the people that Carly is closest to. We may assume it's mum, we may assume it's not dad. It could be a neighbour, it could be a friend, and often they're the people that are part of the circle of the treatment process. And I would encourage, we used to do it in circles, and I encourage clinicians to do it, so that it's just a visual cue of who's really important in Carly's life, and that's a really great place to start.
Oh, thanks, Sean. I think we've got time for one more question here. Developing the initial mental health care plan is hampered by the expectation that the plan is simply the way to better access program. How can we make this plan more meaningful? Surely it has to occur over a number of visits. So I think this is, can I just have a quick mental health plan so I can go and see a psychologist as a GP? And, the community are probably coming and asking us that. So I think it's just trying to slow that process down a little. Any comment?
Well, go for it, Sue.
Yeah, no, I think a thorough mental health plan that includes the head's assessment, but it also includes the things that are most pressing that the young person wants to work on is really important. And I'm wondering if that's what happened with Carly. I mean, maybe the referral was done and it wasn't working towards what she wanted to work on or what was most important for her at that time. So that's the reason why you really need to understand, so that you can do, you know, it's one of the reasons, so that you can do a really good pointed referral. Yeah.
And I think that the way it's incentivized is that you want to get in on that waiting list, especially while there's lots of demand for service, right? So can we do it another way? Can you say, well, book in with a psychologist, let them know the plan's coming, and then, you know, while they're waiting, you continue your formulation, and you could ideally do it over multiple sessions, because you've got to do your longitudinal assessment. You've got to think about all those perpetuating factors, in this case, the neurodevelopmental disorder, the eating disorder, you know, the family breakdown stuff. So all of that stuff needs to go in it to really make it a good plan. Apart from the fact that when you've only got 10 sessions, there's a lot of work that you can be doing in and around it through little brief interventions in primary care, whether it's yourself or your practice nurse or other team members. And all of that, you know, lifestyle stuff can occur too. So you kind of really can break it down and chunk it down, and just see that, you know, that item number is the gate opener, but actually creating a meaningful plan is a process that will actually also help Carly better understand what is going on for her. And I think that can be quite therapeutic in itself.
Don't underestimate what we can do, I think, is the message, isn't it? That, I think that's been just a great discussion on something that I think we all struggle with a little bit. And I feel like I've learnt a lot. So thank you so much. I do want to just remind people that Bianca's, I think you're facilitating some youth mental health echo sessions. That's a weekly. Do you want to talk about? Yeah,
so
that'll be
if you
great.
would like to continue the conversation, Westvic PHN have invited me as a facilitator to run Project Echo. So it's a bit different to COVID Project Echo. These are clinical case-based discussions. So Bo Egan's one of our regular presenters. On Monday, we have Steve McConnell, youth psychiatrist, talking through the risk assessment. So they're kind of really that nice 10-minute didactic presentation followed by a case discussion. So that case-based learning, just like we've done today, only we draw in the participants to be asking clarifying questions and providing recommendations. So it's peer learning as well as learning from our content experts. And it's about what works in practice. So we really kind of interrogate, I guess, those service navigation elements. And look, I think it's really easy from something like Health Pathway, from something like an Echo, where services exist that we might not know about it, we can feed that information back to the Westvic PHN and potentially contribute to that one pager as you describe. So if something like that was to be refined, or we can connect in with the Health Pathways team to hopefully bring what we've learnt from one another to Health Pathways. But yeah, every fortnight, youth mental health. Otherwise, we alternate with alcohol and other drugs, and that's really interesting too. So they're lunchtime sessions, 1 to 2, and they're just over Zoom. Thanks.
Sounds great. Yeah. So I think we draw our conference to a close. It's been such an amazing conference. I think great speakers. Everyone's been so engaged. The questions have been marvellous. I remind everyone to fill out their more in-depth evaluation and give us really frank and fearless feedback about what you think worked and what was great and what we could do better. That's how we learn and how we make great conferences. I think we're going to finish with a prize. I might need help from some of the organisers here. We're going to do it on this session. Yes, we're going to announce the prize winners. So hang in there, everyone, while we. That's like a spinning pluck a duck. Jessica Sambo is the first winner. She wins a $200 voucher. I don't know if she's here, but congratulations, Jessica. Is there another one as well? We've got 2. The other one relies on you filling out the full evaluation online, which will come up on your screen after you leave the meeting. So yeah, I want to thank all our sponsors. I want to thank all our wonderful speakers. We've had such wonderful speakers. I think what it really has highlighted to me, the expertise we have in our health professionals in our region is really fantastic. And the PHN, all the staff at the PHN who've put so much work into getting this off the ground, and participants. So thanks everyone. Enjoy the rest of your weekend, and we'll see you next time. Thanks.